Good morning to all our colleagues in the UAE. A great program coming your way, and it's an honor to chair this first session of this conference, and that I hope that everybody will find very informative and will make it as interactive as possible. The first session today will be have great speakers. We have three presentations. At the end of the three presentation, we'll have a panel discussion. Please, if you did not download the app for the conference, please do so at MinaConf. You can download it in App Store or Google Store, so you can share with us your thoughts and questions live. So my first speaker today, it's an honor and privilege to introduce the first speaker, a great neonatologist, a colleague and a friend, Dr. Peter Davis from Royal Women Hospital in Melbourne, Australia. He's well known to us here. He frequent participant in our conference. And unfortunately, we didn't see him in person in the last couple of years, but inshallah, in the future, we'll see him in person here. Dr. Peter Davis is Director of Neonatal Medicine at Royal Women Hospital in Melbourne, Australia. He has a special interest in this first topic of the presentation in non-invasive ventilation, which led to his MD degree from University of Melbourne in 1998. Dr. Davis, he's a substantial contributor to the Cochrane Collaborative and member of the neonatal subcommittee in the National Liaison Committee of Resuscitation, LCOR, which most of us know that the NRP textbook 8th edition just came on recently. So Dr. Peter Davis will talk to us about minimally invasive surfactant therapy. Is it ready for prime time? Please join me. Welcome, Dr. Peter Davis.
Thank you, and good morning to everybody in the Middle East and elsewhere. And thank you very much to both Junaid and Ayman for the kind welcome. And yes, I'm very sorry not to be with you at this your 11th meeting. I think it's a wonderful program once again. I miss being with you. I miss sharing a meal together with you and our trips to the mosque together. But inshallah, as you say, we'll be together in the not too distant future. So this is a genuinely hot topic, I think, minimally invasive surfactant. We're going to go through the basics, first of all, the respiratory problems of prematurity. And I think you all know this. It's all about surfactant deficiency and how that leads to low lung volumes and airway collapse. It leads to epithelial damage as the lung collapses and then reopens. And as it reopens, protein leaks into the alveoli and inactivates any surfactant that's present. The breathing problems of preterm babies start with achieving and maintaining a functional residual capacity, keeping the lungs open at the end of expiration. These babies need to clear lung fluid. They have very floppy airways that tend to collapse. They also have a very flexible chest wall, which doesn't help them with their spontaneous breathing efforts. And on top of that, they have an immature respiratory drive that leads to apnea. And the natural history of respiratory distress syndrome is a gradually increasing work of breathing, leading to hypoxia and acidosis, and many babies untreated will die. Two treatments we have to help with respiratory distress syndrome: surfactant therapy and CPAP. We'll talk a little bit about the physiology of both. Surfactant, as you know, is a lipoprotein complex produced by the type 2 alveolar cells. It reduces surface tension, improves lung compliance, and prevents atelectasis. Surfactant deficiency is the major problem with neonatal respiratory distress syndrome. And we all know that the surfactant therapy is very effective. It's one of the great joys of our lives to give surfactant and see the baby improve almost on the end of our syringe. CPAP also has a strong biological rationale to help these babies. It increases their pharyngeal cross-sectional area. It stabilises those floppy airways, decreases upper airway obstruction, and therefore reduces obstructive apnea. It also helps maintain that functional residual capacity. By keeping the airways open and dilated, it reduces resistance and the work of breathing associated with that resistance. By keeping the alveoli open, it improves ventilation perfusion mismatch and therefore enhances oxygenation. By stopping that collapse and reinflation cycle, it prevents inflammatory mediators getting into the alveoli and therefore conserves surfactant. All treatments have a downside, and a very well-known one of CPAP is air leak, particularly pneumothorax. There's a theoretical concern that if the pressures are too high, this causes overdistension of the lungs, impaired venous return, and decreased cardiac output. And of course, we've all seen gastric distension as a result of CPAP. We turn to evidence from randomised trials. First, ask the question, when should we give surfactant? And turning to a couple of Cochrane reviews, the first compares early and delayed selective surfactant treatment. And the answer is clear. If you're giving surfactant to babies with an endotracheal tube, you should give it early. That will save lives. More than 3,500 babies involved in this pooled analysis, and a clear benefit to giving early rather than delayed surfactant. These are very consistent results across a number of trials. Similar picture for the outcome of death or BPD, again, more than 3,000 babies, and a statistically significant benefit to giving surfactant early. And just to remind you, this is a message to do with intubated infants. If you put an endotracheal tube down, then follow it quickly with surfactant, and for these randomised trials, that was within 2 hours. The next systematic review frames the question slightly differently. It's prophylactic versus selective use of surfactant in preventing morbidity and mortality in preterm infants. And here we've got a large number of trials, more than 4,000 babies. But I'd like to draw your attention to this little figure down the bottom here. That's the I-squared statistic. It's 92%. This tells us that the results of this pooled analysis are quite inconsistent. There's a lot of heterogeneity present. And while overall, after more than 4,500 babies, there is no clear distinction, although the pooled analysis favours prophylactic therapy, it doesn't quite cross the line of no effect. The trials divide themselves neatly into 2 sets. The first is the trials that had no routine CPAP. These were conducted in the 1990s and showed a clear benefit to the use of prophylactic over selective surfactant. A clear benefit of relative risk of about a third reduction in the rate of mortality. In the 2000s, when CPAP was given routinely, the direction of effect is in the opposite direction and favours selective surfactant. So there's some messages here that are quite interesting. In the early trials, for infants at risk of RDS, prophylactic surfactant decreases air leak and mortality. The later trials, treated in our more modern way, where there was high rates of antenatal steroids and routine stabilisation of these babies on CPAP, there was less chronic lung disease or death with early CPAP and selective surfactant. So there's a tension here. Conventionally, to administer surfactant, we need to have an endotracheal tube with its attendant risks. And there are alternatives, and we'll come back to those shortly. So if we look at endotracheal intubation. We as neonatologists love to endotracheally intubate babies. It's what we do best. It's what separates us from other lesser mortals. But we must admit endotracheal intubation has associated problems. It's associated with acute and chronic lung damage due to volutrauma when we ventilate these babies. It's associated with local airway damage, and in its most severe form, that can lead to subglottic stenosis. And in our immunocompromised hosts, a foreign body like an endotracheal tube is associated with infections, both pulmonary and systemic. So the alternative to putting an endotracheal tube as soon as the baby is born, which we did for many decades, is to start CPAP in the delivery room. And there have been a number of trials that have looked at this question, comparing management with CPAP to early intubation. And we started the ball rolling with the COIN trial, which was an international multi-centre randomised trial, enrolled more than 600 babies between 25 and 28 weeks gestation. And we randomised these babies in the first 5 minutes after birth to either receive CPAP or be intubated. And the primary outcome was death or BPD. So the results of this study were that half of the babies randomised to CPAP were never ventilated. Those babies tended to have less BPD at 36 weeks, and they spent less time on an endotracheal tube. However, they did get more pneumothoraces. Other major neonatal morbidities, no significant differences. So at the end of the COIN trial, we felt that for these babies who breathed at birth but needed respiratory support, management with CPAP seemed to improve outcomes compared with those ventilated from birth. George Smoltzer put together all of the relevant trials comparing CPAP and immediate intubation and found a fairly clear-cut result. Babies managed with CPAP had a reduced rate of death or BPD compared to those who were intubated, and this is almost 3,000 babies. It's not a huge effect, it's about a 9% relative risk reduction, but it's a clinically important reduction. The American Academy has looked at the results of these studies and come up with a number of recommendations, and they agree that early use of CPAP with subsequent selective surfactant administration in extremely preterm infants results in lower rates of death and BPD when compared with treatment with prophylactic or early surfactant therapy, and that's a high level of evidence. The worry always was that if we delayed surfactant, these babies would come to harm, but their conclusions were that preterm babies treated with early CPAP are not at increased risk of adverse outcomes if treatment with surfactant is delayed or not given. So what should we do? Intubate these babies and give them early surfactant, or start them on early CPAP? People have tried to do both. Can we give surfactant to babies on CPAP? Well, yes, we can. We can briefly intubate them, give the surfactant, and then remove the endotracheal tube, the Insure procedure. And that is practiced widely in some NICUs. There is a disadvantage to that approach in that these babies should be sedated. And sometimes, having intubated them and sedated them, we have difficulty getting the endotracheal tube out. Can we give surfactant to babies on CPAP without intubating them? Well, this gives rise to the idea of minimally invasive surfactant therapy. So deliver surfactant to a spontaneously breathing baby who then continues on nasal CPAP. You can do that in a number of ways. You can give it to the baby, inject it into the back of their throat soon after birth, nasopharyngeal installation, and John Catwinkle reported this almost 20 years ago. It hasn't really caught on. More recently, people have tried giving surfactant through a laryngeal mask, and that is gaining some popularity, but again, not widely used. Aerosolization sounds like a great idea. If we can just administer the surfactant through an aerosolizer to spontaneously breathing babies, that would be wonderful, but there have been problems getting the particle size right and proving effectiveness. And again, this is a technique that hasn't really taken off as yet. which leaves the fourth possibility of tracheal catheterization. And so the pioneers of this way of doing things were the German group led by Angela Krebs. And this is their randomized trial, now 10 years old. They compared an intervention group where they passed a catheter and then some surfactant into the babies versus standard treatment. And they showed that these babies had less ventilation in the first 2 to 3 days of life. An accompanying editorial said, "You haven't studied enough babies. We need more information before we can recommend this in general practice." And that led us to undertake a randomized trial of minimally invasive surfactant therapy in preterm babies with respiratory distress syndrome. And this was led by Peter Dargaville, my friend and colleague from Tasmania. So the background to the Optimist trial was that meta-analysis by George Smolzer that showed this small but important reduction in death or bronchopulmonary dysplasia. But we noted that the trial thresholds for intubation in the CPAP arm were relatively high. They varied between 40% and 60% oxygen. And so the question arises, could the benefit of initial CPAP have been accentuated? Could we have got even better results if surfactant had been administered selectively at a lower oxygen concentration to babies exhibiting early features of RDS? And so, as I've mentioned, you can do that in the German way, and the way they do it is use a feeding tube, which is fairly floppy, flexible, and to get that through the cords, the vocal cords, you need McGill's forceps to guide the catheter through before giving the surfactant. Our method, the Hobart method, uses a semi-rigid catheter, and I'll show you a video of that in a minute, and that alleviates the need to use McGill's forceps. So just to share with you this video of how we do it. So this is the catheter. It's a vascular catheter, an angiocath size 16. It's relatively rigid, and you can put a little bend in it to mimic the bend in an endotracheal tube. So visualize the cords with using a laryngoscope. If you've got a competent neonatal fellow, they'll put the catheter in first time very quickly. The baby remains on CPAP throughout the whole procedure. Surfactant is added to, attached to the catheter and injected in 3 or 4 boluses. We're trying to synchronize those with the baby's breathing, but that's quite difficult. We do our best. Baby keeps breathing throughout the procedure. We expect to see a little bit of reflux back up through the vocal cords. And then once the surfactant is delivered, catheter removed, the baby remains on CPAP. So in a PICO formulation, the methodology of our trial, we were asking the question in a population of preterm babies, 25 to 28 weeks gestation, managed on CPAP with signs of RDS. The treatment we're looking at is minimally invasive surfactant treatment as given in that video, comparing that with continuation of CPAP as a control group, and our primary outcome was death or bronchopulmonary dysplasia at 36 weeks post-menstrual age. So this is a difficult trial to run. You have to screen the whole population of preterm babies in that gestational age window, and they had to meet these inclusion criteria. They needed to have CPAP, they needed to be up between 5 and 8 centimetres of water, and in at least 30% of oxygen in the first 6 hours of life. We excluded babies who needed immediate intubation or had some other cause for their respiratory distress, like sepsis, babies with congenital anomaly, or if the treatment team were not available when the baby needed treatment. We needed prospective consent. We tried to blind this study by assembling a treatment team of staff that weren't involved in the baby's care. And that comprised of somebody who could administer the mist. So it's an interesting technique, but usually if you can intubate a baby with an endotracheal tube, you can intubate a baby with a catheter. That was usually a neonatologist or a senior fellow, occasionally a nurse practitioner or a respiratory therapist, and to assist them, a neonatal nurse. Randomisation was performed by the treatment team. There was web-based randomisation to either the MIST or control group, and the babies were stratified by gestation and study centre. So blinding was achieved by screening off the bed space, drawing curtains around the babies, disconnecting any central monitors and putting on a study oximeter so that we could keep track of the heart rate and oxygen saturation throughout the procedure. The control group had a sham treatment, so the baby behind the curtains was repositioned as though it was going to have a laryngoscopy. It didn't receive that, obviously. The treatment team tried to mimic the orders and responses and the noises that they would generate as they would for the MIST group, so suction please, that sort of thing. The intervention for the MIST group, pre-medication was only with oral sucrose and intravenous atropine to avoid bradycardia. The surfactant was given in the way I showed you with that 16-gauge vascular catheter. Or later in the trial, we had access to a purpose-built LISA cath. This was placed at least 1.5 centimetres through the vocal cords for our tiniest babies, or 2 centimetres for the bigger babies. It was inserted, as you saw, under direct vision. 200 milligrams per kilo or 2.5 mils per kilo of Curasurf was administered in 3 to 4 aliquots. Baby maintained on CPAP throughout. There's some animal work that suggests that having the baby inhale the surfactant, draw the surfactant into its own lungs, gives better distribution than forcing the surfactant in on a ventilator. Of course, if babies became apneic or hypoxic or bradycardic, they would be resuscitated with a mask ventilation. After the intervention, babies put back to their original position, standard monitoring started again, and the care was handed over to the bedside staff. And then we surveyed people who were outside the curtain to see if they could tell which treatment was given. After the curtain was opened up, the clinical team were instructed to manage them in this way. If the oxygen requirement went above 45%, as was conventional practice outside the trial, these babies would be intubated and given surfactant, or if they were having severe apnea or persistent acidosis. Other management, the type CPAP could be increased up to a level of 8 centimetres of water, and we allowed nasal intermittent positive pressure ventilation. Primary outcome was BPD as defined by the Walsh criteria, babies on respiratory support or failing an air test at 36 weeks post-menstrual age. The key clinical and safety outcomes, these included a pneumothorax requiring drainage, the need for intubation in that first 72 hours of life, severe intraventricular hemorrhage, either grade 3 or 4, a composite of death during hospitalisation or major morbidity, death or major morbidity, and that was defined as severe IVH, cystic periventricular leukomalacia, retinopathy of prematurity, grade 3 or greater, or BPD. So we'll present the results in terms of relative risks with mean or median differences. Generalised linear modelling was used in the analysis, and we did some subgroup analyses based on gestation strata, oxygen requirement at study entry, and geographic region. We calculated we'd need slightly more than 600 babies to give us 90% power to detect the 1/3 reduction in death or BPD. Babies were recruited in 11 countries, 33 centres, and we had an interim safety analyses conducted by an external monitoring committee who instructed us to continue enrolment. However, we had to stop in March of last year. We got to 80% of full recruitment, but we were just unable to recruit further babies because of the COVID epidemic. This brought our power down to 82%. Here's our consort diagram. I'm not going to go through this in detail, but I'll draw your attention to the vast number of babies that were screened, more than 5,000 babies screened. We lost about half of them because they were intubated. They were too sick to go on the trial. And then there were another almost as many babies who didn't ever reach that 30% oxygen requirement in the first 6 hours of life. Most families consented to the trial, but a few refused consent, and that brought us down to 488 babies enrolled. These are the babies that I hope you would recognise. Babies on average 27 weeks gestation, 900 grams birth weight, roughly 50-50 split boys and girls, a reasonable proportion, predominantly twins. About a third of our babies were twins. 2/3 of our babies had complete courses of steroids, high caesarean section rates. Babies enrolled quite early on in life, about 3 hours of age, on CPAP levels of around 7 and then 35% oxygen. There were some imbalances in our gestational age strata. So we had the more immature babies, 25 to 26 weeks, and the more mature babies, 27 to 28 weeks. It just so happened by chance there were more boys in the control group, fewer girls, more multiples in the mixed group, and a lower rate of steroid dosage in the mixed group. So some higher risk babies fell into the mixed group in the smaller gestational age strata. Here's the primary outcome of the study. So death or BPD, the trend favours missed. The relative risk is 0.87, but the whisker just crosses the line of no effect. The p-value is 0.088. For death, no significant difference, but a statistically significant reduction in physiological BPD, highly significant at p equals 0.01. So it gives a risk difference of 8%. So treat 12 babies with mist to prevent one case of BPD, a highly effective treatment. Other important outcomes is almost a halving of the risk of pneumothorax in the mist group, a big reduction in the need for intubation, non-significant reductions in grade 3 or 4 IVH or death or major morbidity or morbidity overall, a trend towards increased death in the mist group, was not statistically significant, p-value 0.30. Here's the performance of the babies with respect to intubation. You can see the control babies in blue were intubated more frequently during the first 24 hours, and that difference was maintained right through to 72 hours compared to the missed babies in orange. In the gestational age stratum, we found that the outcomes, death or BPD and BPD, were similar between the two strata. The difference was in death. The more mature babies seemed to have a lower, the outcome favoured missed, whereas in this lower gestational age strata, more missed babies died than control babies, so the outcome favoured control. Nothing statistically significant there in either of the subgroups, however. A couple of highlighted secondary outcomes require for surfactant via an endotracheal tube, halved in the missed group, less PDA requiring therapy, less intubation at any time, and a reduction in home oxygen therapy from 22% down to 15%. All of those results statistically significant. Some other respiratory outcomes, decreased time on an endotracheal tube from 4 days to 1 day, and just overall a reduction in days of all mechanical respiratory support from 45 to 40 days. Some safety outcomes with respect to the missed procedure. It was thought that the trachea was successfully catheterised 100% of the time, and only one attempt was required in 3/4 of the cases. About 10% of babies were thought to experience undue discomfort, bradycardia in about a third, hypoxia in about 40%, 14% required some positive pressure inflations, but only one baby needed intubation at the time of the missed procedure. It was thought that about 12% of the time the treatment was ineffective. I suspect this may have been the catheter going down into the esophagus rather than the trachea. How well did we blind? Well, we're not sure, but when we asked the staff outside the curtain what they thought had been given, a third said they were correct in their guess. 10% were incorrect. Most were unsure. So in summary, compared with the continuation of CPAP, the missed group showed no clear reduction in death or BPD, but an 8% absolute risk reduction in BPD in survivors, a halving in need for intubation in the first 3 days of life, and a halving of the rate of pneumothorax. And some other benefits: reduced PDA, reduced duration of mechanical ventilation on an endotracheal tube, reduced duration of all forms of respiratory support, and less oxygen therapy required at home. So this is the largest randomised trial comparing surfactant delivery via a thin catheter with any comparator. It's the only blinded study. We think that this technique of delivering surfactant is widely applicable. The limitation, the main one, is the loss of power that we experienced when we stopped recruitment short of the original target. The incidence of the primary outcome and of death was higher than we anticipated. And we really need to follow these babies up into infancy to get an idea of what the long-term effects of this intervention are. But our conclusion is, and I think we're fairly confident about this, selective application of MIST in preterm infants with RDS reduces the risk of BPD and other morbidities, lessens the burden of all forms of mechanical respiratory support. So I'm going to stop there, thanking, if there's anybody in the audience who helped with this trial, thank you very much. It was a big effort from around the world, but particularly I'd like to thank the babies and their families, and these are some of our babies who have now grown up. So thank you very much for your attention, and we'll take questions, I think, at the end of the section.
Thank you very much, Dr. Davis, for a really great presentation. I'm sure it's going to be sparking a lot of questions at the end of this session. Now we're moving to the second presentation of this session for Dr. Junaid Khan, who doesn't need any introduction. He's well known to all of us here in UAE for all his efforts in putting this conference and together and leading the neonatology service in many hospitals throughout the UAE. Dr. Junaid Khan is Director of Medical Education and he's Associate Program Director and Consultant Neonatologist at Sheikh Shakhbout Medical City in Abu Dhabi. He is American Board Certified in Neonatology, and he has a lot of publications in peer-reviewed journals, editorial boards, and he presented many international conferences. And as I mentioned, he's well known to all the neonatologists in the area. He's going to talk to us about an interesting topic related to inhaled nitric oxide in preterm newborns and what is the evidence. Please join me welcoming again Dr. Junaid Khan.
Thank you. Thank you very much, Dr. Rehman, for a kind introduction. I am doing this for the last 3 years, and I sandwich myself between two talks of Dr. Peter Davis. It's very difficult to talk when the speaker like Peter Davis is going to be present. So anyway, I did it myself, and then I prepared the agenda, so no complaints. Uh, this one is like a controversial topic, the use of inhaled nitric oxide in preterm infant. Yes or no? I will try to give you the evidences, I will try to give you the recommendations, and then you will decide yourself in your setting that you can use it or not, and what condition you can use. I have to say that I'm using some figures drawn or created by my friend Dr. Satyan from California, Davis, University of Davis in California, and he did a lot of work in this regard and pulmonary hypertension. So my objective today is to understand the mechanism of action of INO and discuss the potential effect, review the trials of INO in the preterm infants. Now, this is the prime trials initially which we had is 25 meters, 750 grams, 6 hour old, high frequency and PIE with oxygenation in 22, 28 weeks, 1150 grams, 36-hour old, SIMV with oxygen requirement of 35% and 25 weeks, 780 grams, 10 days old on CPAP with oxygen requirement of 40%. Now, the primary outcomes, they want to know the survival without the bronchopulmonary dysplasia. But before I discuss these trials, I have to go through about the nitric oxide and how it works. So this is a new, molecule which is invented in 1992. Is a naturally occurring molecule. Our body also producing it. In 1992 it claimed is the molecule of the year. It regulates our vascular tone, is gas exogenously administered to the lung, is potent pulmonary vasodilator. We all know about that in cases of pulmonary hypertension, especially with the pulmonary hyperplasia, we are using it. And of course, after the invention of this thing, it reduced the need of ECMO for those patients. The mechanism is simple. Inside the body, the L-arginine is converted to L-citrulline plus nitric oxide with the nitric oxide synthase, the enzyme. It goes into the smooth muscles and it's try to open the calcium channels and the putting the potassium outside through the potassium channels, and this all can relax the smooth muscles and ultimately the vasodilation and decrease the hypertension. In 2005, I will try to go all the studies in the chronological orders. In 2005, this is the animal model, in the room model of, and they want to find it out the effect of the INO on the chronic lung disease. And what they found out, the control in the, if you can see here, the compliance is higher in INO group as compared to the control group. Here, the expiratory resistance is higher in the control group as compared to the INO group. Similarly, the control group has less volume with a higher pressure as compared to the INO group, which has more volume with a similar or a little bit less pressure. So it really helping in this model to help or to ease out the ventilation. So this is happening that the same article suggests that it can improve the lung growth, and if you can see on the right hand of your, on the left hand of your screen, that the lung weight is increased and is statistically significant as compared to the control. Also, the DNA content is increased with the building material of our organs is significantly increased. No difference in the protein content, and also the cell proliferation is also increased. So it really, in animal model, it helping to improve the lung growth. The INO use in premature in 37 US children hospital is starting very high, and then it is NICU volume patients per year, it is started decreasing. But still, there are a lot of units which are using it. So the INO use in these 37 hospitals is the size of the propensity to be treated with INO is increasing. Okay, so the mortality percentage is going up and down. Okay, so it's not really correlated with the use of the INO. Now, the rationale for use in the premature RDS has some component of pulmonary hypertension. It improves the VQ mismatch. Dr. Peter Davis talked about the VQ mismatch in the RDS. IMO has other effects on airway resistance and surfactant function, and also it affects the lung development, as we saw in the model. So this is the causes of hypoxemic respiratory failure in the neonates. How it is developed is the figure drawn by Dr. Satyan, and what he's saying that there's a lot of things going on which can lead to the hypoxemic respiratory failure. The bidirectional shunt, the bidirectional at the PFO, acute pulmonary vasoconstriction, genetic defects, intrapulmonary anastomotic vessels, impaired pulmonary venous drainage, and alveolar capillary dysplasia. So all this can help to develop this disease, which we call hypoxemic respiratory failure. And this all lead to the cyanosis in preterm babies. So other than the congenital heart disease, this is the flow diagram that what will happen, and it is very easy to understand that if you have a left ventricular dysfunction, low left cardiac output, left to right shunt through the PFO, right to left shunt through the PDA, the oxygenated blood return to the pulmonary circulation, which can give you the desaturation and the cyanosis ultimately. And similarly here, the low pulmonary blood flow, right ventricular dilatation, right to left shunt, and PFO shunting, they decrease the PVR, decrease the right to left shunting, better PVF and oxygenation if we are on this side of the this flow diagram. So this is the one way to understand the physiology, what is going on in hypoxemic respiratory failure. The short-term and the long-term benefits. The short-term benefits, we all know pulmonary vasodilation, improve VQ mismatch, reduction in inflammation and neutrophil accumulation. But the long-term benefits are the reduction in oxygen stress, improved surfactant function, improved alveolarization, and reduced vascular remodeling and improved vascular growth. Having said that, but it is not that all these potential benefits we can apply in all type of the pathology. So, for example, if we have the hyperdynamic pulmonary hypertension or pulmonary vein stenosis, mitral stenosis, LV dysfunction, this is not going to be work. The gray or the pink area, which is there really chances that the INO work in the preterm lung. For example, the abnormal transition, asphyxia, acidosis, hypercapnia, hypoxia, PPHM due to MAS or pneumonia. And the gray area, we don't know that if it really work or not. We will go through some evidence. There are potential toxicities of the INO, like methemoglobinemia, platelet dysfunctions, and the generation of the nitrous oxide, unknown additional toxicities in preterm infant, which can lead to the damage their lungs and their cardiovascular system. The inhaled nitric oxide for respiratory failure. So this is my first thing to discuss, that what are the evidence? Is really it help in this pathology, or it help in decreasing the BPD? Let's see some evidence regarding that. So there are studies of INO and preterm infant. There are multiple randomized control trials, but the major difference in timing when you should start the INO right from the delivery room or the later. What is the dose? Start from 20 ppm or the 5 ppm or in between. How much is the duration and what is the real population for that disease? So as I told you, these are the three major studies done in different time in 2005, 2006, and then again in 2006 to see the effect of INO in preterm infants. So the earlier rescue with INO is suggested by Myers and his colleagues, published in 2005 in New England Journal of Medicine. He really chose a very less than 34 weeks and birth weight is 401 gram to 1500 gram. Oxygenation index to start this treatment is more than 10, eligible for 4 to 120 hours of age. And initial dose of 5 ppm every 4 to 8 hours. Responder defined increase by the PO2 by 20 mmHg in 30 minutes. So it's really, they want to start INO as soon as possible and see the effect. So the major outcome, death or BPD is not statistically significant. Death alone is not statistically significant. BPD alone is not statistically significant. Same with the grade 3 or 4 IVH and PVL and the severe ROP. The major outcome by the birth weight, if you can see less than 1000 gram and more than 1000 grams. Death or BPD, no difference. The difference in the less than 1000 gram, the death is higher and it is statistically significant in the INO group. The BPD is not any difference and the severe IVH is higher in the INO group in the less than 1000 grams. And if you can see more than 1000 grams, the death of the BPD is statistically higher again in the placebo group, and the death is higher in the placebo group. BPD alone is higher in the placebo group, but not statistically significant and similar to the severe IVF PVF. So there's a very mixed type of thing, but definitely less than 1000 grams have a side effect of the can be the effect of the or adverse effect of the INO on that. This is the 2020 study by Dr. Satyan and Chandrasekhar. Is just published September last year. Early hypoxic respiratory failure and extreme prematurity, mortality, and neurodevelopmental outcome. They have almost 8,000 infants in NICID unit research network, less than 26 weeks, less than 1000 grams. The maximum inspired oxygen is more than 60 and less than 60. In a group more than 60, they labeled as early hypoxic with respiratory failure and they exposed to INO. Its death by 18 to 26 months is 59%. Moderate to severe NDI or neurodevelopment among survivors is about 44%. Those are not exposed to INO, the death is about 49%, and the neurodevelopment adverse outcome is about 41%. If it is less than 60, the death is about 20%, and the moderate to severe NDI among survivors is about 30% who are not exposed to the INO. So really, it is a very different study, and it is showing us that INO has this adverse effect in those babies. This is the same in the which I just mentioned about that this thing, but it is the early hypoxic respiratory failure alone, then plus INO, and then plus INO with the norm of this thing. So this is the same which we just talked about that. Then 2005 and 2020, Then 2006, we have another study which is late INO at risk infants. So these are the two early rescue INO. Now this is the late INO at the risk infant. They choose less than 32 weeks and mechanical ventilation or CPAP at 7 to 21 days, and initial dose is 20 ppm times 72 hours. The major outcome, again, the death of BPD is that is the placebo is 63.2%, and it is statistically significant. Discharge at 40 weeks post gestational age is also statistically significant in that in the iron group. But the death alone and the 44-week discharge is not significant. Survival without BPD is 7 to 14 days. In INO group is higher. 15 to 21 days is not that much higher. The racial division, the white, no difference, but in black Americans, kids are statistically significant in the INO group. Other finding, what we find it out is less severe BPD with INO, no acute change in pulmonary mechanics, less use of bronchodilators at 12 months, cost effectiveness, no difference in developmental outcome, no evidence for other toxicities, and it improves effective function. So again, there's a very mixed results of what we are getting. So the questions are: trial selected out infants who survived first week. Is INO is most effective in infant at high risk to develop BPD when started earlier? So at what time we should start? Is there any racial difference in INO effects? Because one study I just showed you, there's a difference between the white race, Caucasian race, and the black American race. Does longer therapy at a higher dose provide additional benefits? These are the questions arise. The INO administration trial, which we just talked about, they have they are the 4 trials, and they use different doses. The Ballard trial used 20 ppm, and then 10, and then 5, and then stop. The Schreiber trial used 10, and the Kinsella trial used 5, and randomized also used 5. So there's a heterogeneity among these trials also. If then all these 4 and 5 trials and the other trials, then in 2011, there's a meta-analysis published in Cochrane Review, sorry, in Pediatrics Journal by Askey and his colleague. And what they found it out that is there is no difference in outcome if you compare to the death or the chronic lung disease. Similarly, the primary outcome combined favor the INO and favor the control is no difference. As you can see, they are all crossing the line of confidence interval. The meta-analysis for the secondary outcome, which is death by 36 weeks, death by discharge, severe IVL, gross air leak, pulmonary hemorrhage, and the severe ROP also not different in this meta-analysis. Outcome by dosage and durations, and same meta-analysis, death of the CLD and duration of INO treatment is not that difference, and it is crosses the line of confidence interval. So there is no agreement on that. Then there is one trial which is called the Neuro trial. This is the pilot study. The PPOP population is the infant less than 1250 grams, less than 30 weeks. Intervention is randomization to INO and comparison with the INO with no placebo. Outcome increased survival without BPD, and the time limit is the 36 weeks post-menstrual age. So INO dosing, they begin with 20 ppm and for 70 to 96 hours, and decrease to 10 ppm until day 10 plus minus 34 hours, and then 5 ppm to complete 24 days of therapy. Therapy continued through 24 days, even if the respiratory support no longer needed. So this is a long therapy for 24 days. So there must be a cost effectiveness for this therapy also. This is done by Dr. Yoder in 2014. So these are the INO for declaration of the PPD, and these are the randomization. Placebo is 222, INO is 229, some loss follow-up is completed at 36 weeks is 204 in one group, placebo group at 208, which is almost similar in IMO group. The results are like this. Survival without BPD at 36 weeks post-menstrual age was similar between the placebo and the inhaled nitric oxide group. So imagine how much cost you incur for 24 days of INO, and the results are the same. There is no difference in incidence of common morbidities were observed. Respiratory outcomes on discharge at home at 1 year and at 8 to 24 months is also did not differ in between the groups. So the conclusion at this point, Dr. Yoder made it that IM was safe and well tolerated, no difference in primary outcome, did not improve survival without BPD or respiratory and neurodevelopment outcome at 18 to 24 month premenstrual age. After this study, there is a consensus report published in the American Academy of Pediatrics, use of inhaled nitric oxide in preterm infants, and they are against to use it, and they said that I'm reading the same what they wrote. The result of randomized control trial, traditional meta-analysis, and individualized patient data meta-analysis study indicate that neither rescue nor routine use of IM improves survival in preterm infants with respiratory failure. And the evidence quality they give A, and the grade of recommendation is strong. The other statement they make, the preponderance of the evidence does not support treating preterm infant who have respiratory failure with INO for the purpose of preventing or preventing the BPD, severe IVF, or other neonatal morbidities. And evidence quality is high, and the grade of recommendation is strong. In 2015, the off-label use of inhaled nitric oxide after release of NIH consensus statement, which I just did by the Reese Clark group, and what they conclude that the rate of off-label INO use in the preterm infant continue to rise. So the people are still using it after those statements, despite evidence revealing no clear benefit in the population. This pattern of INO prescription is not benign and comes with economic consequences that we just saw. And the off-label use, they are using it in the preterm infant, the prolonged rupture of membrane, PPHN, ductal right to left shunt, bidirectional emulsion, hypoxic respiratory failure, preterm infant, to prevent the BPD, cardiac catheterization left, sometimes they are using it, and non-invasive. In September 2020, the trial or European Union nitric oxide trial, they published their 7-year follow-up of those babies, and they found it out that for prevention of BPD in very premature infant with respiratory distress did not result in long-term benefit or adverse long-term sequelae. In the light of current evidence, routine use of IM cannot be recommended. So this is the very latest in September 7, 2020. The similar reports published for the respiratory failure from 2016 in Cochrane database, which shows no difference between the control group and the IMO group when you look at the mortality, when you look at the ECMO. Yes, when you look at the ECMO in this meta-analysis, they favor the IMO group. So inhaled nitric oxide in extremely weak neonates with respiratory distress syndrome, which is the conclusion in 2018. After all that is off-label prescription, is not associated with reduced mortality BPD among extremely premature infants. These are very prospective trials. Because of the time, I'm going to now, the association of early inhaled nitric oxide with survival of preterm neonate with pulmonary hypoplasia. So this is the another study published in 2018 that if you have a hypoplasia plus PPHN, the exposed babies with INO has a better result as compared to unexposed. But if you have a hypoplasia but no PPHN, then there is no difference between the exposed group and the unexposed group. This is the last study which is just published a couple of months, I think it's in July, went to say no to inhaled nitric oxide in neonates, and they mentioned some absolute contraindication, for example, vector-dependent lesion, and they very beautifully illustrated by Dr. Satyam and Steve Appman in this Europe. The other, they want to absolute contraindication is a severe left ventricular dysfunction. So if you have the cardiac problem, it is better to not use the nitric oxide. So the practice point, they said the use of INO in preterm high proximic respiratory failure due to pentamer disease without pulmonary hypertension is lack evidence, and they not recommended it. Recommend selective use of INO with HRF due to PPHM. Maybe we can use it. Routine INO used for prevent BPD is not recommended, and in neonates with the CDH associated with LV dysfunction and pulmonary hypertension, use of INO can potentially lead to respiratory deterioration. So this is the last point, is very important to understand, because whenever we have diaphragmatic hernia, maybe we are trying to rush to start nitric oxide, high frequency. It is not that recommended now. We have to do the echo first, see the LV function. If the LV function is good and there is a significant persistent pulmonary hypertension, then obviously then you can think about INO, but do not jump at the CDH with, you have to start with the nitric oxide. So to end with, so what do we know right now? Is there any benefit of INO use in extremely low birth weight? The answer is no. Benefit of early low dose INO in the ELBW. Is INO affect the lung development? Yes, in the animal model it can affect lung development. Is INO increase the risk of brain injury? Yes, it can increase the risk of the brain injury, especially if we have the babies less than 1,000 grams. Is INO recommended in documented pulmonary hypertension? So documented means if the person who is well trained in the echo do the echocardiogram and find it out as the pulmonary hypertension, then yes, it is recommended to use the early INO, like I showed you, the hypoplasia plus the PPHM in it helps the babies. Should we encourage use of INO and HRF? No, we shouldn't. We should discourage it. We should maintain it by giving surfactant, by the LISA technique, and to try to continue with the CPAP. Most of the babies improve on that. It's not then just intubate the baby and try to give the gentle ventilation. Need for randomization trials of vasodilator in BPD patient to assess efficacy? Yes, there is need for those trials. That's all. We will take the discussion, and thank you very much. Back to you, Dr. Ayman.
Thank you very much, Dr. Junaid, for interesting presentation. I'm sure it's going to have a lot of questions in a discussion session. We're moving to the third presentation of this afternoon, this evening, Australia time. Keeping the theme on PPD and how we avoid PPD and treat. So Dr. Peter Davis is going to shed some light on strategies to avoid and treat bronchopulmonary dysplasia, what works and what doesn't. Dr. Peter.
Thanks, Ayman. Yes, this is an interesting topic. It's one that we face every day in the neonatal unit, isn't it? BPD is endemic amongst our patients, so we're going to take an evidence-based approach to see what works. Just some background. What is BPD? Well, it's a chronic lung disease of prematurity, as we all know. It's common. It affects at least 35% of babies less than 28 weeks gestation. What we call BPD has evolved over the decades of modern neonatology. In the early days, and perhaps right up into the 80s, we had this syndrome, which we now call old BPD, initially described by Northway in 1967, which arose on a background of RDS with high pressure ventilation and oxygen toxicity. And the pathology seen there was cystic emphysema and fibrosis of the lungs. In 1999, Alan Jobe described what he called the new BPD, a term that's stuck. And this is in the era of antenatal steroids, surfactant and gentle ventilation, but we were still seeing a problem. And he described it as a problem of arrested alveolarization and pulmonary vasculature development. And when we think about the pathogenesis, we shouldn't be at all surprised that our babies have problems with their lungs. Our babies at 24 to 28 weeks are in the canalicular or early saccular phases of lung development. They're a long way off having mature airways and alveoli. And so at this very vulnerable stage of development, we take them from the uterus and expose them to high concentrations of oxygen. We have trouble providing good nutrition. We expose them to inflammation and sepsis, and cardiovascular instability, particularly patent ductus arteriosus. So it should be no surprise to us that these babies' lungs do not develop properly. BPD is a disease of long-term consequences to respiratory health. These babies spend more time in hospital during infancy. They have higher rates of wheezing and asthma in childhood and perhaps into adulthood. They have measurable changes to their lung function, airflow limitation and decreased exercise capacity. And not only do they have lung problems, they also have brain problems, problems with neurodevelopment, an increased risk of cerebral palsy, cognitive deficits, and behavioural problems. So BPD is a problem for us in the nursery and a problem for paediatricians, families and children throughout life. And it's a problem that's not going away. Here's some US data that shows that mortality over the years 2005 to 2014 fell steadily. Chronic lung disease really stays fairly stable, particularly over the last 5 or 10 years, up to 2014. Here's some data from Australia, which is even more alarming. If we look at babies between 26 and 28 weeks, we've seen their rate of chronic lung disease increase steadily, small amounts year on year, to the point where 2 years ago, we're well over 40% of babies with established BPD in that gestational age stratum. So we've got a big problem. We'd like to find some evidence-based solutions to that problem. We'll start with the easy one, surfactant we've already mentioned today. Natural and synthetic surfactant, whether you give it prophylactically or give it early, all of these surfactants reduce death or BPD, that combined outcome. It turns out that they don't reduce the isolated risk of BPD, but certainly reduce the combined outcome of death or BPD. And just a quick recap if anybody joined late. Minimally invasive surfactant therapy is one of the treatments that really does reduce BPD. Remind you that was a risk difference. If you expose the baby to minimally invasive surfactant, you reduce their risk by 8%, treat 12 babies to prevent 1 case of BPD. Moving along to caffeine, and these data come from the Caffeine for Apnea of Prematurity, or the CAP trial, led by Barbara Schmidt. And we know a few things about caffeine. We know that it's good for getting babies off respiratory support, whether that's intubation, any positive pressure, or supplemental oxygen. Babies exposed to caffeine come off these therapies about a week before placebo-exposed babies. Highly significant results, clinically important results. But we're talking about BPD, and caffeine is one of the most effective treatments for BPD, reduces the risk from 47% to 36%, highly statistically significant. So there's a mechanism of action here, isn't there? If we get babies off the ventilator, away from volume trauma, they're less likely to have BPD. Some added benefits of caffeine: reduces rates of PDA and PDA ligation. But of course, the reason for doing the CAP trial was because we were concerned with the effect of caffeine on the developing brain. There was some animal work that suggested it might be harmful. So we were quite reassured at the end of the caffeine trial when we found that caffeine actually improved rates of death or disability, reduced in the placebo group from 46% to the caffeine group 40%. Again, a highly statistically significant result. So caffeine, a great way of reducing BPD. Treat 9 babies to prevent 1 case. Has added benefits, economic, and for the babies, it gets babies off supplemental oxygen and off the ventilator sooner, and it does so safely from a neurodevelopmental point of view. So whenever we find an effective treatment, we're always tempted to use a little bit more of it. So I think it's important we go down this little byway and ask the question, is more caffeine better? And there have been a couple of systematic reviews that have looked at this question in recent years. Some of our colleagues in Sweden and in the Netherlands wrote systematic reviews close to one another. Just draw your attention to some of the common themes that emerged. The first one is that the quality of evidence that they found was low to very low in both systematic reviews. So both sets of authors suggested that these were small trials, small numbers of trials. Even when we put them all together, we had insufficient infants to answer the question about safety of higher doses of caffeine. As I said, the quality of the included studies was low to very low, but there was a hint that higher dose caffeine reduces BPD and extubation failure. And these authors both independently called for a large randomised trial to determine the optimum dose of caffeine. I did a review of this topic if anybody's interested in more of our thoughts about caffeine. This was published last year, and included in that were some observations that I think are particularly pertinent. 3 years ago, it was observed that the rate of prophylactic caffeine use on the first day of life, being perfectly stable for about 10 years, trebled within the 6 years after the CAP trial was published, to the point where 2/3 of babies were getting caffeine on day 1 of life. Again, my hero, Alan Jobe, has got a nice word for this. He calls it treatment creep, and pertinent to caffeine, he cautions clinicians that particularly in high-risk populations like our very low birth weight babies, we should be using these drugs only for sound indications. And so for clinicians, I think caffeine is one of our most widely evaluated drugs. Its safety and efficacy have been well established for a specific dosing regime and applied over a duration considered appropriate at that time. And that was starting on around day 3 and finishing at around 34 weeks corrected gestation. If you've got a baby with a problem, a baby with apnea or a baby about to be extubated, caffeine is terrific. It's indicated. You can prescribe caffeine with confidence. But there is little high-quality evidence that caffeine is a safe and effective brain drug or lung drug, and its use in asymptomatic infants not requiring respiratory support does not appear to be warranted. The doors are open for researchers. It is plausible that caffeine prescribed earlier and continued longer than that used in the CAP trial, it might be better for our babies. But, and this builds on Junaid's experience with nitric oxide, something can look biologically plausible. You can have great evidence in animals, but you take it to a human and you might find the opposite. And we've got some examples here. Delivery room oxygen. Clearly, too much delivery room oxygen is harmful. Postnatal dexamethasone, using it too early and in too high doses is likely to be detrimental. Hypothermia therapy for hypoxic ischemic encephalopathy is great. It's wonderfully effective. But prolonged or deeper cooling for these babies is harmful. So this demonstrates what appears to be logical extensions of a proven therapy may mislead us into fruitless byways or disasters. So I would suggest that adequately powered randomised trials, at least the size of the CAP trial, 2,000 babies, with follow-up into infancy and beyond, are required to test these hypotheses and determine the safety of higher dose, longer duration of caffeine. Next, I'd like to talk about volume-targeted ventilation. And again, there's a physiological underpinning for this, the hypothesis that volume-targeted ventilation might be better than pressure-limited ventilation. And that relates to the theory of volutrauma, or over-distension of the lung, rather than pressure being the cause of preterm lung injury. And there's a strong theoretical reason to think that stable tidal volumes might reduce lung damage and also stabilise carbon dioxide levels in the blood and have a beneficial effect on the brain. So we undertook a review for the Cochrane Library. This was published 4 years ago, hasn't been added to. And just to look at the quality of the evidence, and we should always look at the quality when we look at a meta-analysis, and you can see that although we've got 20 randomised trials, the number of babies is quite small. We've only got around about 1,000 babies in these 20 trials, so they're quite small. The other thing to notice is this red area, and this refers to the unblinding of these trials. Very difficult to blind trials of ventilation, maybe impossible. Otherwise, the trials are of reasonable quality. But interestingly enough, the bottom line with respect to BPD is that volume-targeted ventilation successfully reduces the risk of BPD. The relative risk here is over to the left of the line of no effect. It's a statistically significant result. It results in an 11% absolute reduction in the risk of BPD. It's a highly homogeneous result, it's a very consistent result across all of the trials, in spite of them using different settings and even different ventilators between the two groups. This volume-targeted ventilation has a number needed to treat of just 9 babies to prevent 1 case of BPD. Similar findings if you use the combined outcome of death or BPD, treat 8 babies to prevent a case of death or BPD. So it's a treatment worth using. So I should say there is no difference in mortality alone, but some important benefits in other interesting neonatal outcomes, like pneumothorax, a halving of rate of pneumothorax, about a halving of the rate of severe IVH, and a similar reduction when you combine periventricular leukomalacia and grade 3/4 IVH. So, in conclusion, volume-targeted modes had reduced rates of death or BPD, reduced pneumothoraces, hypocarbia, severe cranial ultrasound pathology, and duration of ventilation compared with infants ventilated using pressure-limited modes. We need follow-up studies for these trials to test what it does to neurodevelopmental outcomes and to compare and refine the strategies that we might use when we volume target babies. Not time to go into details of how to apply volume targeting in a specific sense. If you're interested in this topic, we published an article 10 years ago giving some tips and tricks as to how to make volume targeting work in the real world. Next, I'd like to move to postnatal steroids, and to cut to the punchline, the risk-benefit ratio of postnatal steroids varies with the timing, the baseline risk of the babies, and the route of administration of the steroids. Cochrane Library divides this topic into 2, early steroids and late steroids. So starting with steroids begun in the first week of life. Lots of studies and more than 4,000 babies, and the evidence is on the whole high for the major outcomes. The results, no difference in mortality. Early steroids do have some benefits. They increase the rates of early extubation. They actually reduce BPD and patent ductus arteriosus. But they come at a cost, and quite a severe cost. They have increased risk of gastrointestinal bleeding, risk of intestinal perforation, hyperglycemia, hypertension, and growth failure. But most importantly, there is evidence of early steroid therapy leading to long-term neurological harm, particularly increased risk of cerebral palsy. The authors of the review noted that the harm was associated with dexamethasone and not hydrocortisone, but the numbers of trials with hydrocortisone were quite small. So their conclusions were that the benefits of early steroids may not outweigh the risk. More long-term data were required, and particularly more trials of hydrocortisone are worthwhile, powered for long-term outcomes. And in response to this, the Premiloc study was conducted in France, low-dose hydrocortisone in extremely preterm babies. It's a reasonable size study, about 500 babies, and showed a reduction in, an improvement in survival without BPD from 51% in the placebo group to 60% in the hydrocortisone group. That's a p-value of 0.04. No difference in rates of the components of that primary outcome. No improvement in neurodevelopment at 2 years. And Michelle Schaffer and colleagues have performed an individual patient data meta-analysis on all of the trials of this question and found some promising results, but some problems with the trial. There was high rates of open label corticosteroid use in this trial, so the non-randomized use of steroids, which muddies the waters considerably. But they did find that early low-dose hydrocortisone increased survival without BPD at 36 weeks from 46 to 53%, decreased death before discharge, decreased PDA treatment, but no difference in some of the important respiratory parameters. The downside, and there always does seem to be a downside, is this common theme of increased spontaneous GI perforation and, in this case, an increased late onset sepsis, and no evidence of a benefit in terms of long-term neurodevelopment. So for us, around the world, people have reacted differently to these trials. We're not using low-dose hydrocortisone. We were concerned about the modest and imprecise treatment effect from the trial and some lingering concerns about exposing all extremely preterm babies to early systemic steroids. So this is a topic where we watch this space. More information needs to emerge before I think we can use this treatment with confidence. If we move to the late steroid trials, fewer numbers of trials and fewer numbers of babies, but still more than well over 1,000 babies. And again, the overall quality of the evidence is high for the major outcomes. So with respect to the outcome of death to latest follow-up, no significant difference in rates between the steroid and the control group. The steroids do decrease risk of BPD, take the relative risk down to 0.77. And the combined outcome also reduced in the steroid group, death or BPD. Again, there's the downside of steroids: hyperglycemia, hypertension, and gastrointestinal bleeding. Long-term, rates of death or major disability, no difference between the steroid and control groups. And the conclusions of these authors were, I think, appropriately cautious. Benefits of late steroids might not outweigh the risks. May reduce mortality without increasing long-term neurodevelopmental risks, but the quality of those long-term studies was limited. The authors of this review suggested we keep late steroids in reserve for babies who were unable to wean from the ventilator. And if we're going to use steroids, then we use the lowest dose for the shortest duration that we can get away with. Looking at why some trials of postnatal steroids are giving mixed results and posing something of a riddle. Jack Sinclair, sadly no longer with us, but a very original mind in neonatology, had a great idea of solving this riddle. And his hypothesis was that the baseline risk of BPD determines the treatment effect of dexamethasone on the combined outcome that we worry about, death and cerebral palsy. That is, that steroids are more likely to do harm if the risk of BPD is small. And he proposed using something called weighted meta-regression analysis, which I'll show you in a minute, to test that hypothesis. So we found 20 studies and more than 2,000 babies eligible for this meta-regression, a mixture of early treatment studies and later treatment studies. And this is what we found. So on the x-axis, we have the risk of BPD in the control group, so the baseline risk of BPD going from 0 up to 80%. On the y-axis, we have the effect on death or cerebral palsy. Here's 0, the line of no effect. Above the line, the control babies do worse, or steroids are causing harm. Below the line, steroids are causing benefit, reducing risk of death or BPD. And so you can see this hypothesis was confirmed that when the risk of BPD was low, the risk of steroids doing harm is quite high. But as the risk of BPD increases to the point where we get to 50 or 60%, then we start to see that steroids are actually doing more good. We repeated this exercise several years later when more trials became available, and this proved to be quite robust. The finding was quite stable. So if systematic steroids have a mixed result, would we do better if we give the steroids another way, by other routes? One theory was you could give metered aerosol steroids, inhaled budesonide, and Dirk Basler led a large study asking this question, more than 800 babies, and asked the question, did this improve death or BPD? So in the budesonide group, the primary outcome of death or BPD was lower in the budesonide group, and the p-value just hit the 0.05 mark. So there was some enthusiasm, maybe the answer had been found, but in the detail, when we look at the components of that primary outcome, we see that actually the death rate was increased in the budesonide group, compensated by a marked increase in survival without bronchopulmonary dysplasia in the placebo group. So babies with budesonide benefited in a BPD sense, but suffered in a mortality sense. Long-term follow-up showed no important differences between the two groups. But then when they looked at death at 2 years, the combined outcome, death or disability, was exactly the same. So 59% in each group, nothing going on there. But that difference in death in mortality rates now becomes statistically significant, and it favours the placebo group. In other words, budesonide is associated with a higher mortality than no treatment. And so I think our interpretation is clear. Inhaled steroids are not the solution. What about steroids mixed with surfactant and given soon after birth? And Dr. Ye from Taiwan has pioneered this way of thinking and has done a number of randomised trials. This is maybe the most important, where he randomised 265 babies, very low birth weight babies. These were quite unwell babies. They were on the ventilator. They were at least 50% oxygen in the first 4 hours of life. And he mixed budesonide with Savanta. So Savanta, as you know, has got quite a high volume, not terribly widely used around the world. The control group just got standard Savanta. This was given 8 hourly until the oxygen requirement came down or the baby was extubated. Most babies had 1 or 2 doses of the surfactant. So the thought here is that by mixing the steroids with the surfactant, we get great distribution to the alveoli that needed the inflammation to be damped, and this would be more successful. And so it proved to be. There was a great reduction in that combined outcome of death or BPD from 66% in the control group to 42% in the treated group, and particularly in moderately severe BPD. So a great clinical benefit, but perhaps we're a little bit sceptical about the magnitude of that benefit. There was a corresponding lower oxygen requirement during the first weeks of life, no obvious adverse effects that were seen with systemic steroids, and a mechanism of action. The steroid reduced things like interleukins in the first week of life, so a mechanism by which the steroids dampening inflammation and then going on to reduce BPD. They did follow their babies up, but not as well as we might have liked. The follow-up rates were less than 90%, but they found no difference in neurodevelopment at that later follow-up. So we are a little bit suspicious because of the small sample size and the large effect size. Savant is not commonly used because of its larger volume required. The restrictive inclusion criteria imposed on these babies, just the sickest babies, and the potential for bias. So some methodological concerns about this trial and incomplete follow-up. Nevertheless, we think this is a very promising therapy. So we are more than halfway through a trial. We're going to recruit more than 1,000 babies. We're up over 600 now, combining Curacert with budesonide to see if we can reduce BPD. And I hope we'll be able to share that with you, the results of the hospital outcomes anyway, within the next 2 years. So I'm going to stop by summarising that the treatments that we can use to reduce BPD safely are caffeine in the doses and in the timing used in the CAP trial, volume targeted ventilation, postnatal steroids if we target those two babies at highest risk. And then on the horizon, we've got steroids plus surfactant. I haven't had time today to mention stem cells and exosomes, which are a little bit more towards the horizon. But just like to acknowledge the contribution of someone known to perhaps some of you at this conference, my friend Amir, who led a seminars in fetal and neonatal medicine chapter on this topic. And if you're interested in reading more about BPD and the treatments available, I recommend this one to you. So thanks for your attention, and ready for questions.
Thank you very much, Dr. Peter and Dr. Junaid, for really exciting presentations. I have a ton load of questions. I'm going to go through one by one. So I'm going to alternate the questions. So I'll give you the break. And we'll try to get as many questions as the time allows. For Dr. Peter, the first question we have is that there was a publication in 2018 about focal intestinal perforation in LISA for babies under 26 weeks. I know your study in MIST did not show any difference in intestinal perforation between the control and the MIST group. Why do you think the difference in between these two studies? Is it related to sample size? Is it related to the surfactants? Can you comment on this?
Yeah, I'm not sure is the honest answer, Eamon. I don't know. There's sometimes we get random effects. Spontaneous perforation occurs occasionally, doesn't it? We seem to have many epidemics of it, and then it goes away. I suspect that that's the case here. It's a random effect. We will watch it in future trials, but as you say, we found no evidence of it in our study, and I'm not aware that other studies have found a similar problem. So it's something to file away and to keep an eye out in future trials, but I don't think it's something that we need to particularly worry about.
In our guidelines that we did in our hospital, we try to start with MIST in the babies over 32 weeks. So just to kind of be on the safe side, just to start with. But since you didn't find any difference, what kind of surfactant do you use for MIST?
We use Curacert because it's a small volume, and like you, while we were waiting the results of the trial, we started trying it in our more mature babies and got a feel for it. Those babies perhaps are a little bit more stable during the procedure. also, if you let them get big enough, they will fight you a little bit more. So that's a problem. But I think that's a very sensible approach to try it on the bigger babies and then work down as you become more confident with it. We did find some issues when we started to roll it out to our junior staff, and we were much less confident they were putting the catheter between the vocal cords, and we've moved back to restrict the people who administer the surfactant to the more experienced fellows and consultants.
Great, thank you. Question, Dr. Junaid. What is the long-term adverse effects of inhaled nitric oxide?
As I mentioned in a few of the studies, especially if the babies are less than 1,000 grams, the neurodevelopmental index at 18 and 26 months follow showed that there is a decrease in NDI. Not only that, the immediate effect of grade 3 to 4 IVH and PVL is higher in less than 1,000 gram babies if they use the INO. So this is just mention the evidence which I showed you.
Okay. Question to Dr. Davis. During NIST, should we put an open orogastric tube in the stomach during installation of surfactant?
We don't routinely do that. I guess most of these babies will have a nasogastric tube in because they've been on nasal CPAP. We wouldn't put one especially down. It's a useful way of diagnosing whether the operator has put the catheter between the cords or down the esophagus. If you get the same volume up through the nasogastric tube, you can be pretty sure they've picked the wrong hole. But yeah, so we wouldn't put one down specifically for it, but most of our babies would already have one down.
Thank you. Dr. Junaid, how do you explain the benefits of inhaled nitric oxide in pulmonary hypoplasia, knowing that the vessels are not formed?
Yeah, so as I mentioned, that pulmonary hypoplasia didn't show any benefit, but with the pulmonary hypoplasia plus the PPHN, persistent pulmonary hypertension, that is a benefit for that. So this is answer the question, is the answer in the question, because in pulmonary hypoplasia, the vessels are not that developed. So they don't have the PPHN, but if they have the PPHN plus the pulmonary hypoplasia, yes, there is a benefit.
Thank you. Dr. Peter, what is the best type of catheter to use in MIST?
Yeah, we used the vascular catheter for a long time because that was all we had available to us. That was a size 16 angiocath, and that's perfectly fine. We were a little bit nervous that the edge of that, the end of that catheter was a little bit sharp, and we worried about causing some damage to the trachea, but we didn't ever see that. But nowadays that we have the purpose-built catheter, the Lisa cath, we would preferentially use that. It's got a rounded, beveled end, and we feel more secure there, and it's got markings on the catheter to guide you to put it at the correct depth. So that's what we'd be recommending.
That's good. I think that you answered this in a question in your presentation about sedation during this. I think you said that you use Cypros. Anything else? Anatropine. Anything else you use?
No, when we started this process, we were quite concerned, and people said, look, if you're going to put a laryngoscope down a baby's mouth, that's going to be uncomfortable and you should sedate or even muscle relax the baby. But we thought that was sort of defeating the purpose. And so we tried with just some sucrose and atropine. The nurses who are the guardians of our babies seemed happy that we weren't disturbing them too much. It sort of adds weight to what I was saying about using an experienced operator who can do the job quickly, like the young lady in the video there, minimising the distress. And that way we rationalise just using those measures that I described.
Dr. Junaid, I think you mentioned this. What is the risk of IVH in using the INO for premature babies? I think you mentioned this.
Yeah, I mentioned it. This is more in the less than 1,000 grams, the grade 3 to 4 IVH.
Do you have a percentage?
I don't have the percentage, but it is statistically significant.
Question for Dr. Davis. What about vitamin A used to reduce the risk of PPD?
Yeah, that's. I didn't get round to that. That's an interesting question, isn't it? And vitamin A is definitely shown to reduce risk of BPD. There was a large trial done in the US. The problem with that trial was it was intramuscular injections of regular intramuscular injections of vitamin A, and I think the public voted with their feet and said that the pain of those injections is not worth the small reduction in BPD. The benefits, we certainly include vitamin A as we do all other vitamins, essential vitamins in our day-to-day care of these babies, but the intramuscular doses have not really taken off.
There's a question about inhaled or aerosolized surfactants. Anything about that?
Look, that is the holy grail, I guess you might say. If we could get that right and not have to put laryngoscopes down babies' throats, then that would be wonderful. There have been a couple of small trials in bigger babies that have shown an effect, but in treating our little babies, we're still waiting for evidence that it's going to be effective. There are some new nebulizers being developed that we think might optimize that droplet size. So the problem was always being the droplet size was either too big and the surfactant would precipitate out before it got to the lungs, or it would go all the way into the alveoli and then come straight back out again. But as the nebulizer technology gets better, it may be in the future that this is a great treatment, but not just yet.
I think that the technology have to evolve around having aerosolized surfactant that's small enough to go to the alveolar part of the lungs and not precipitate in the airway, and not heated to kind of make it the surfactant not useful.
Exactly.
So that's the technology they're working on. So the questions, I have another question about sedation that probably just somebody joined in. Just an update on, we have a 3,652 colleagues registered now, and among them 1,468 are logged on right now. So I'm getting a lot of questions, but I don't have, we exceeded the time and the break.
Just one minute, I have some question. Peter, very welcome again. I have a question about the release. I did in my previous job, and we did in a very small baby, even in the cartoons, and they are 26, 27 meter, about 800 to 1,000 grams each, and none of them require ventilation. So I really have a very good experience with them, and not only those, I have a group of let's say these type of maybe about 40, okay, and I have data for that, and only 3 of them failed CPAP after that. So really, what do you think? It is going to be the future? It is going to be the standard of care? What do you think at this point?
I think that's right, Junaid. We're very confident now. We were always waiting for the result of this trial to reassure us, but you're ahead of us, and I think this should be standard of care for babies on CPAP. It just gives us a really nice way of avoiding endotracheal intubation for those babies. I think particularly 25 weeks and above. I'm not sure that we're going to be able to keep the tiniest 23, 24 weekers off the ventilator. But the bigger babies, yes, I think it's very well worth a try.
The other question, sorry, Eamon, I'm just taking one or two questions. The Curosurf you are using, but you know that Curosurf, right now we are also using a Curosurf. We have this legal document because of the Islam and all those things. But let's say if you have not available Curosurf, or the parents refuse to use the Curosurf, with that technique, do you have experience with other surfactants?
We don't, Junaid, but I don't think that's a deal breaker. I think it's probably technically a bit more difficult if you're using a volume of surfactant that's greater. But look, I think it's, having shown it works with Curasurf, I don't think there's any reason to think it won't work with the others. It might just be a little bit more clunky. It might take a little bit longer to administer. That you might have a higher rate of desaturations during the procedure. But I don't really think it's the surfactant that makes a big difference.
And last but not least, at least I am very patiently two things: to meet you in person and your plus trial. Plus trial is going to be game changer if it is going to be available.
We hope so, Junaid, and even if we see half of the benefits that our Taiwanese colleague demonstrated, it will be worthwhile. But as I made the point all the way through this evening, we've just got to be really cautious. Things that sound really good sometimes turn out not to be good. But I'm very hopeful that the PLUS trial will represent a major breakthrough.
I got a signal from the organizers that we can go a little bit longer with the questions because we're getting more questions as we go. As long as it's not too late for Peter, it's going to be late in the evening for you.
The sun has just gone down.
Okay.
We're okay.
We have a question about established or severe PPD. We have a lot of strategies to prevent, but how about strategies in treatment of established and severe PPD?
Well, nitric oxide doesn't work. Look, I don't have any magic. We don't have any magic. We use as much steroids as it takes to get these babies off the ventilator. We will occasionally use vasodilators if we've proven the baby has pulmonary hypertension. But they're very difficult, aren't they? And I'm afraid I don't have the magic wand to say, try this. We've started some trials on stem cells, and we're learning a little bit about the pitfalls, about the administration of them. There's a long way to go before they're an established therapy, but perhaps that's where we're going to end up, stem cells or exosomes therapy to try and allow the lung to regenerate more normal morphology.
Thank you very much, both Dr. Davis and Dr. Junaid, for really nice session to start out our conference. There's a lot more to come. We're going to take a short break. And thank you, Dr. Davis. We'll hope to see you in person next time.
Yeah.
Inshallah. Inshallah.
And I hope, Peter, if you can join at least our ventilation session. This is tomorrow in the morning, so your evening again, if you have time. So I can ask more questions to you.
Look forward to it.
Okay.
Thank you very much, both. And we're going to take a break for about 10 minutes, and then we will get back with the second session. Thank you very much.
Thank you.
Thank you.
Thank you very much, Dr. Junaid, for your inspirational opening remarks. Before we start the first session of today's agenda, I would like to make a few announcements. We would like to acknowledge the following organizations, companies who supported this event: Children's National Hospital, USA, Children's Hospital of Philadelphia, USA, KC Pharmaceuticals, Sobi Pharma, Roche, Prolacta. We urge our attendees to visit the booth of our supporting organizations. If you are interested in their products and services, please feel free to drop a message on the chat box. The representatives for each of these companies are eager to meet up with you virtually. We invite everyone to join the symposium with Dr. Boris on nutrition of preterm babies, lessons learned from cow's milk derived fortifiers. It will be aired tomorrow, 15th October 2021 at 2:55. We encourage all our attendees today to participate in the panel discussion by sending your questions to the speakers of each session using the send a message icon on your screen. This event will close at 7:25. Today's first session in the agenda is respirology in relation to units, and I welcome the chair for this session, Ayman Rahmani. He is American board certified